evidences about who are all there in the last time?
Oh, I'm saying that. So, who all remember those things that I talked last year? Some of the things. So, only two people are there. I'm very well qualified to repeat the lecture again. But then, last time we discussed only about top physiology, if I remember correctly. They are passed. Oh, good. So, hopefully.
Proof of the pudding.
So, this time it's going to be a whole lot of these both cyanotic and all types of. What are the diseases that you are likely to encounter? So I'm happy to share the slides. So you don't need to capture the photographs. Right? You can have receiver mechanism to get these slides. So the primary purpose of these slides is to educate everybody. So what are the things that you are likely to encounter? So it's very simple. One is cough and cough-like conditions, Cynotic syndrome, and extreme anomaly. These are the three things you are likely to encounter. Among the top physiology, various top physiology that you are going to encounter, and there is something like what is known as triology of Fallow, that is PSC intact reticular septum, and then pulmonary dyspnea, and then top absent pulmonary. These are the three variants of tetralogy you are likely to encounter. And Cynotic syndrome and FG, these are the ones that like rarely we encounter, common atrium, pulmonary fistulas, and all those things. And rarely as a trend, because getting patients, especially in southern part of the country, is becoming difficult, you start getting operated cases, like visa and the cases. So you find patients who have some palliative surgery done. You have to be aware of the common palliative surgery that are done. So let us get to question mode. So all of you are very hungry, so I am going to test you with some questions. What is the most common congenital heart disease at birth? Teaching? Or tetralogy. How many think it's tetralogy? Most common congenital heart disease at birth? TG. Sure? Not there? So actually it is TG. So the most common congenital heart disease at birth is by far TG. The tetralogy comes nearly a third actually if you look at it. So hypoplastic left heart is also far more common than tetralogy, which is intuitively you never think like that. But then this is what it is. These are the numbers. They are across the spectrum. They remain the same. But unfortunately, look at the survival percentage. The survival in other forms of disease are very very bad. That is why after a while we always end up getting only tetralogy. This is some important concept to understand. So what is the cause of cyanosis in an adult? We are just now going to focus on adulthood because once you go to the infancy, then you go to cyanotic test, oxygen test, and all those things. It's a totally different ballgame. Diagnosing giving in an adult. So we now focus ourselves to cyanosis in an adult. So we can easily classify it into these types like cyanosis, where common defects with expected survival. India's approved only we have two, that is cough and Cynotic syndrome. Uncommon defects with the expected survival are FG anomaly, ASD. And then uncommon defects in which adult survival is exceptional, you have plenty of other things that we always have. I've just put it in small parts that they are so small, they are very rarely seen. But having said that, these are the longer survivors in these because the CCTG is 91 years reported. So you can find some variations also. So how do you approach an adult in CCH? Because one question is out. One case is going to be RST and another case is going to be some group velocity. So the questions are going to be difficult. You present, they are going to say, what do you think now after the history? Is it going to be tetralogy or Cynotic syndrome? You know the question. But oftentimes you falter in answers. Because we commonly don't have an approach. It cannot be so simple than approaching a cyanotic adult. So what are the million-dollar questions that everybody faces is whether it's tetralogy or Cynotic syndrome? How do you approach from this? Very simple things, nothing else is there. So you are going to look at the quantum of cyanosis, when the cyanosis started, how the cyanosis progressed. It's all about cyanosis. When it started, how it progressed, what is the severity of cyanosis. That's what you're going to look at. And then you look at whether the patient has history of cyanotic stress or history of scratching with their arm. So that's all is there. Examiner cannot manufacture anything more than this. So how are you going to narrate this, and how are you going to interpret this, and how are you going to conclude this? That's what that history question is all about. So simple that. It's a first standard person's job. Am I right or wrong? So look at into some of the details. So like this is a very classical thing that is often said, like at what age commonly heart failure happens. Based on this, the etiologies differ. For example, left-to-right shunts have heart failure maybe around 6 weeks of life when the PVRS starts to fall. So, when you have at birth to 72 hours, most of them are AV valve revestited lesions and critical semilunar valve stenosis, that is AS and PS, MR and DR. Then you have, next is hypoplastic right or left heart syndromes come up for heart failure. And then you have the transposition complexes, endomyocardial fibrosis and coarctation of aorta. Then you have to go to the other lesions like PSG and others come up. The same thing, similar thing can be proposed for cyanosis, onset of cyanosis. When does a patient become cyanosed? So, commonest cause of cyanosis, most of the in birth and first week is generally TGA, pulmonary atresia, very rarely critical cough almost behave like a pulmonary atresia, and obstructive TAPVC, HLHS and Epstein's around. Epstein's, you know, has bimodal presentation, one in the early neonatal period and infancy and one in the adulthood. Same thing as some didn't answer you properly well was the coarctation heart failure, same thing. One early and one late. So same thing. So then you go to, later on you progress further, beyond first decade it's tough. Everything is going to be tough. So in between a few months to 2 years you have TAPVC and other balance physiologies and truncus comes into between. Truncus that you start with maybe acyanotic, then in between it becomes cyanotic, then later on it becomes isomorphic. So beyond third decade, generally it is tough, ALT Eisenmenger syndrome, CCTG, VSD, PS and CK23 PS. These are the likely possibilities where the patient's longevity is possible. So other specific history features can maybe formed. So balance physiology will be like the classic single ventricle promoter CCTGs, where the QP QS is nearly 1. So VSD, PS, yeah. So other specific history features you may find in some of the things that may help you. This one is definitely age and cyanosis and history of heart failure is there or not, and then failure to thrive. So failure to thrive indicates in infancy failure to thrive is there. That means the patient has gone through a phase of increased pulmonary blood flow cycle, or has some syndromic associations, or has absent pulmonary artery. These are situations where failure to thrive is common. Then patient can have hemoptysis. History of hemoptysis means generally cause for Eisenmenger syndrome or pulmonary atresia. And tachycardia we always discussed what are the cause of palpitations these are all like I'm not talking about these are arrhythmic palpitation. History of arrhythmic palpitation fixes it to either Epstein's anomaly, AVSD, CCTGA and heterotaxis syndromes. And then syncope can be because of structural lesions like PS. Very rarely in Eisenmenger syndrome you can have syncope, or AV blocks because of AV canal defects, heterotaxy and CCTGA. Now we are moving on to top physiology at first.
Why heterotaxis include?
Sir, it's basically it's a problem of AV junctional defects. Right? So AV block and extra circuit. We are talking about AV extra circuit or AV block happening. So you need a connection abnormality between AV and AV. All of them are connection abnormalities between AV junction. So when you have a connection abnormality at AV junction, having another pathway or having an abnormal node is more common because of the long path it takes for the AV node. So then the chances of overtime blocks developing becomes higher. So moving on to top physiology as a whole. So simple, top physiology means unrestricted VSD, severe pulmonary stenosis, severe, again, great. So oftentimes it's a trap. Every examiner wants to put you on the trap and everybody falls into the trap. So what is the trap? You have a pink tetralogy. Why is the pink tetralogy is pink? And invariably the answer is they have less severe case. So no, even in that pink tetralogy, the PA pressure is going to be 20 or 22 max, and then your systemic pressure is going to be, RV pressure is going to be systemic, that is 120, the PS is going to be severe. But what makes the pink tetralogy pink is the quantum of pulmonary blood. So we now from our understanding of low gradient AS, we understand even though as clinicians we want gradient, flow and the effect has to be linear. It's not linear, we understand. For example, for a critical stenosis, there is low gradient there, low flow there. Here again, it's a critical stenosis, the flow can be maintained. The opposite is happening in pink tetralogy. We really don't understand why that particular fellow is having a good flow. So maybe it's related to the overall RVOT volumes, RVOT resistance that is produced. We really don't understand. So, but that is where it is. It's not because of severe, less severe case. So they are classified under decreased QT, and the physiology is right to left shunting happening at the ventricular or aortic level. This is what is the physiology, hemodynamics. So coming to cyanosis in tetralogy, these are some numbers. I think some examples are part of asking, but something you may know. So basically, like around 25% of tetralogies are cyanotic at birth, and 75% of cyanotic by around 1 year of age. So history of cyanosis is generally at rest and crying or activity, and invariably you must measure cyanosis with exercise in your exams. Unless the patient is clearly class 4 or something, it's better to document a 6 long distance into time. And the date appearance of cyanosis, why the patient initially is not cyanosed, while later on the child becomes cyanosis, because the demand of the child is increasing. There is a progressively increasing artery obstruction that keeps on happening. If you look at the OT, if somebody goes into OT and sees the OT, long-standing tetralogy, the whole artery becomes like a parchment. It's like at times the knife also bends. It becomes really tough to cut. So it becomes, the flow makes it so thickened and it's fibrotic. So after birth, there is a slow change from HbF to HbA, which is better carrier of oxygen than the latter one. And invariably, they generally have normal growth or weight gain, except for these some syndromes. Then spatting, history of spatting. So we all know that why spatting relieves cyanosis. So spatting will relieve cyanosis, whatever be the mechanism of cyanosis. It is not specific to tetralogy. So then it is been reported in some of the Indian series in 3 to 10% with isometric syndrome also. So that knowledge you should have. So it's not absolute that okay, somebody has spatting must be tetralogy, and if you rule out isometric, it's more likely to be tetralogy. So then there are some spatting equivalent that all of you know of, that is sitting with legs drawn downwards, legs crossed while standing, and then all those things are some of the various things. And the cyanotic spells, moving on to cyanotic spells, it is the age at which the spell occurs. It's very, very peculiar. We don't understand that also. Generally, the age for spell is roughly around 3 months to say around 2 to 3 years. After that, the spells disappear generally. Maybe the patients with severe spells actually disappear. Either they get surgery or they die, or there is some other mechanism at play. So some other theories have been proposed, like various theories have been proposed why there is spell. Because we ask most of the things in cardiology, we don't understand the basic things. Like we really don't understand why there is spell. Even though it's very simple to say that spell is because of increasing aortic spasm. But we all have seen enough number of times pulmonary activity is presenting to the spells. So that means this mechanism alone is not sufficient or not enough to explain spells. So there has to be something else at play, and these are some of the other things that can be at play. So hemodynamics is very simple to think that anything that reduces pulmonary vascular resistance, increases pulmonary vascular resistance, that is increase the resistance to the pulmonary arterial flow, and that reduces the resistance to systemic flow, that is in systemic venous dilatation or vascular dilatation. That includes anemia, fever, all of them will precipitate as well. So what are the clinical findings in tetralogy? So the clinical finding in tetralogy, you are not supposed to find anything major. If you find anything major in tetralogy, think of something else. So nothing is there. Even seconds of this, which are single. So nothing is there. No major murmurs. The JVP is normal. JVP is not elevated in most of the patients. There can be a D. A waves are prominent in adults with tetralogy. So that is roughly found in around 30% of patients. With adults with tetralogy can have A waves is prominent. But otherwise, you don't have a JVP elevation. There is no cardiomegaly, no heart failure, no parasternal impulse. Systolic release is uncommon. Single second sound. Murmur which is inversely proportional to cyanosis, and there is no added sound. So literally, you don't find anything. If you find anything, start thinking of some of these conditions. That is, you got USPPS, BPS, PGA, CCDGA. When do you suspect all of them? Some of the things that we discussed. Some of the hardest thing that you can find is an enforced pulsation. You find a pulsation, a palpable sound here in the left second stage. That is left and anterior aorta. So my left and anterior aorta will be somewhere here. If you find a pulsation or a palpable sound here, that indicates that it's likely to be an enforced aorta. LV impulse is a very characteristic finding, I think, which was very well answered in that case. So tricuspid atresia, single ventricle are the ones that are commonly there. Even though they are not top physiology, Epstein's anomaly and PILS, are uncommon conditions that in adults can present with LV impulse, and a very rare condition that can be associated with an AS like heaving epical impulse would be DORB with restrictive AS. What is this DORB with restrictive AS? Is DORB. That means both the data cells are arising separately from RB. They have no connection with the LV, not even overriding anything like that. So this DSG is the only outlet for that element. So that DSG is getting restricted. That means it's like an LVOT obstruction for that ventricle. So it is going to behave like a device. But it's an extremely rare condition. So I would have seen in my life maybe around 7 or 8 cases in total till now, maybe around 23 years of practice. So it's a very rare condition. So then another important thing that if you come out is the murmur out of proportion to cyanosis. This I would use this opportunity to again reiterate the physiologies at play. So murmur out of proportion to cyanosis means you will get a very loud murmur in the pulmonary artery area. That means the pulmonary artery blood flow is very good. There's a good murmur in that. If it is very bad, because we know in tetralogy it's inversely proportional. So if it is very good murmur, either the septum is intact, that we are not dealing with, the VSDPS physiology is there. But something else, despite having a good flow, something else is making the patient blue. That something is either admixture physiology or a transposition physiology. What is hemodynamic hallmark of a transposition physiology? Is step down is very simple to understand. Step down means LV saturation, there is a step down happening in the iodic saturation. That's a step down physiology. What is the classical hemodynamic hallmark of a TGA physiology? So PA saturation will be more than iodic saturation. So that alone is producing cyanosis. And admixture physiology will be all the saturation will be same beyond the chamber of admission. So that again can produce. Any of them can be producing this. So then you have murmur at ABPR that suggests generally ABSD or CCTJ. Early diastolic murmur of PR, either it is AR or it is, so PR it is absent pulmonary block, complete heart block, mesocardia, dextrocardia, any change in position then it is absent of CCTJ. And generally cyanosis is much more in a TJ physiology and in DORB physiology compared to a single ventricle or CCTJ where relative terms cyanosis is less there. And then survival is like pretty bad in tetralogy also. Tetralogy is best among the worst. That is why tetralogy is there. So look at it, survival in tetralogy is also not so great. So that's why everybody should be operated, even if they are asymptomatic and bimetrical respire is possible. So everybody should be operated. Just a brief outline of all the surgeries that happen for these tetralogy-like physiologies is what are the factors that determine the timing of surgery. Is the need for surgery, whether symptoms and cyanosis is there, and whether the anatomy is single pump or two pump, or you have the need for conduit is there, and the expertise of your situation, and then associated lesions determined. In children, what we generally do is whenever two ventricle repair is possible, in any condition, we nowadays go for two ventricle repair always, almost always. So nowadays every center has its own policy, but all across the centers, roughly around 5 months, 6 months is now considered the cutoff for operating. Total repair, under there is a conduit is needed. So if the conduit is needed, generally it is done at around 1 to 4 days of age. Before that, if it is needed, we go for a palliative procedure. That palliative procedure nowadays is shifted from BT shunt to more into catheter, where we do either RUT stenting or PDS stenting or even balloon pulmonary valvotomy as the case may be. When it comes to single ventricle pathway, so you either go through a BT shunt, we are not talking about only VSDPS physiology. So it will be BT shunt. The Glen is generally done at around 4 months to 1 year of age, and then Fontan at around 3 years to 4 years of age. This is the standard practice in India, but sometimes we generally go from BT shunt to Glen to Fontan. This is the classical pathway of progression, but rarely you can go directly from a BT shunt to Fontan, or very rarely in an adult presenting directly we may go for a Fontan. So these are the situations that arise. But the same algorithm in an adult is going to be two ventricle pathway means almost always ICR, whether the patient needs a conduit or not. Palliation is only when ICR is not possible in an adult. And the same in two ventricle physiology, shunts and Glens have no role really. Why Glen has no role in an adult? Anybody? There's a hemodynamic physiological understanding behind it. So the proportion of blood flow that comes from into the upper part and lower part changes by around 7 years. So Glen, if you do a Glen, there is hardly any quantum jump in the cyanosis in an adult. So even for some reason you do a Glen, It's better to convert them into a fontan very quickly within 6 months' time rather than going for a direct fontan. So generally, in majority of situation, high risk direct fontan is a preferable option in circulation physiology than go through this classical mediation, blend, and fontan process. So coming to the differential, now we have discussed about top. Now we go to some of the limiters of top. Like the top and top physiology we discussed about. The other condition which you should remember for your exam is a triology of Fallow, which was initially called. Now we commonly call it as ES with intact ventricular circle. Here, whatever we discussed about, everything is going to be here because the circle is intact. The RV is going to be in trouble. So there is heart failure, there is JP elevation, there is cardiomegaly, there is a good murmur which is proportional to the degree of obstruction. So everything is going to be there. So there is a dominant A wave in JUP and the wave becomes CD wave when the onset of TR and heart failure. Then you have cardiomegaly, parasternal impulse is there, and then S2 depends on the pathology. There is RB S4, it's definitely there in severe CS, but it becomes S3 with the onset of RB dysfunction. And then pulmonary systolic murmur is proportional to severity and it's a late peaking long murmur, and then you can have a PR murmur. So TR murmur. These are the things that are there. Coming on the pulmonary atresia, the simple thing, pulmonary atresia, you don't get an RVOT murmur. From a clinical standpoint, you don't get an RVOT murmur because it's atrophic. So you are not getting RVOT murmur, and you may get collateral murmurs more prominent. So then you start thinking of pulmonary atresia. So generally it's around 5 to 10% of petrology physiology. So some of the things that for pediatric adults to remember is around 25% of them may present with heart failure due to increased flow in infancy. This is not a common way we think about VSD pulmonary atresia. And then generally the rest of things are common, and then click is more likely to be there. So some of the tips to get out of trouble, so these are the various pictures we have put together, like congestive heart failure in adult petrology is reported around 15% of patients. Hypertension is around 6%, AR in around 7%, ECG may show LVH in around 1%, absence of RVH is around 3%. So these are the ways to get out of trouble when you are faced with the situation. So everything is possible. So what are the causes of heart failure in petrology? Because this is a common question that almost always happens. So you should all remember. I think it's very simple. One structural reason, that is restrictive USD. We have anemia, infected myocarditis. All the valves around it can leak. So AR, can have PR, can have TR. So all of them cover almost everything. Then you have ventricular dysfunction. The surgical shunts can produce that. The collaterals will come really late because collaterals are never good enough to produce heart failure. Because once they are good enough, they are not cynos, they are much better than low. And then arrhythmias very rarely later in life, hypertension and AS can come. So some of the things that you should all remember, some of the examiners are fond of asking is some of the percentages, how often you find right arch, pulmonary this and that. You should remember it. Syndromes associated with tetralogy, what is catch-22, what are the features of catch-22, how do you diagnose, what if there is a catch-22 in a tetralogy versus if it is not there, why there is boot-shaped heart, why there is early transition in ECG, and the post-op tetralogy issues. Because of want of time, I can't cover everything. There's enough of spoon feeding for today, so you should go and read some of these over time. So moving on to Eisenmenger syndrome. Similarly, this is the major thing that we need to discuss. So some of these I also don't know, like sometimes the examiners know these things very well, so they keep on asking. I don't think the relevance of asking followed series, how many patients are there, how often, how many are going to turn into Eisenmenger. Still that many people are asking. It's good to know the history, but how much you should know, I never ask this. But maybe this is an unfortunate patient, that's what we are dealing with. The same patient X-ray I put together, the same patient personally at our center at around 3 years of age, the child was operable, and the same patient comes back around 10 years later, where the VSG has settled into an Eisenmenger syndrome. So these are unfortunate patients that we keep on seeing. So basically it is again step down happening at the aorta, the ventricular level, or the arterial level. So due to increased pulmonary artery pressures and reduced pulmonary blood flow, most commonly due to VSD, PDA, AFib into ASD, or some of the rare cynotic and rare disease increased QP can turn into Eisenmenger syndrome. So generally, this is a very important fundamental question that all of you should be very clear about. At what age at VSD, large VSD will Eisenmenger? Well, 10 years, how many for 10 years? Raise your hands. Nobody? 20 years? 2 years? 6 months? So all of you get it right. Many of you have noted was the most common code. So what you have to understand is isomerization is a process. As in cardiology or any other field of medicine, we want dichotomous answers. We want, okay, you are operable, you are inoperable, or you are pass, you are fail. So that is not how the life or nature goes. So it's a process. So isomerization is a process. The process starts very early, maybe around 6 months of age. The process of irreparable changes in the pulmonary vasculature starts to happen. So the process of isomerization is generally established by around 1 to 2 years. The patient can become inoperable. There are some situations where the patients become isomerized much early. That will include CCHT with increased QT, that is your truncus arteriosus, your TGA VSD pH, your DOR VSD pH, all those things can become isomerized far early. And some of the syndromic things like Down syndrome or some of the other defects or some genetic syndromes are there, that isomerization can be very early. And then one more dictum that is there is, when in doubt, never operate on these children, because the median survival is without unoperated is around 30 to 40 years. So in uncomplicated cases, this is a very classic graph that has been repeatedly shown, but that has been now challenged. That you should understand. So if you are interested, you can go back to the articles and some of the Swedish registry from population that has been reported. So this graph is no longer considered true. So a patient of isomerization is also having a bad prognosis when they come with clinical heart failure, when they come with severe cyanosis and symptoms. They don't follow the curve that has been there. So this is because of what is known as an immortal bias. As clinicians, we always record the people who are coming to us, keep on following us, and we forget about people who are eliminated. So this is very good article, multiple articles come on this, but immortal bias in isomerization, we can go and read about it. But still it is much better than IPH. So I used to teach that the isomerization syndrome commonly clinical group wise presents in 3 subgroups. One, the most common, the prototype that we all understand is recurrent respiratory tract infection in childhood, failure to thrive, later on there's a quiescent period, everything is fine, maybe goes weight is there because typically are settled now, typically is around 1.1, the circulation cyanosis is also like mildly cyanosed and with exercise in versus everything is perfect for normal growth, the child is growing nicely, but around 10 to 20 years later, the child starts to become having symptoms due to isomerization syndrome. That's a classical prototype. But there is another group, maybe roughly around 30 to 40% of all isomerization that we see in India have what is known as insidious presentation. They don't record anything like this in early childhood. There is nothing on record. Like patients don't remember, or patient has forgotten this, or it doesn't go through this form. One of the reasons that has been proposed is, anybody? Why they don't have passed through this cycle that of recurrent respiratory infection, failure to thrive. It is persistent because that means the PVR has never fallen down. So they remain with an elevated PVR throughout their age, so never gone through the cycle of increased flow and failure to thrive and heart failure. And the rare one is these cyanosis in birth. They are very common till 10 years of age. Beyond 10 years, the survival is very limited. That means your TGA, NCCST increased to be close to become isomerization. So some of the key concepts that are generally ASDR, cyanosis and radial gauge and DSG and PD because these are bidirectional chunky that can occur. They become isomerization. And JLP has a prominent A-wave and DO is seen only in 5 to 20% of patients, those who have a LV to RH shunt or a mitral registration. So heart is not enlarged in general except for an ASD, and P2 is loud and palpable in 2/3 of cases, ejection slipped in most of the patients. The EDM of PR in 1/2 to 2/3, 10% can have a thrill, and we'll discuss about P2 and the etiologies generally. So I told you, like, compared to tetralogy physiology, cyanosis in isomerization syndrome is generally mild in adolescents that will present with isomerization syndrome. And there is absence of heart failure and cardiac failure, minimal left external lift is there generally, and absence of a significant shunt numbers will be there, and signs of PH predominant. So what are the signs of PH that are there? It's a loud palpable P2, a palpable RCS3 or S4, palpable pulmonary pulsation, and peripheral fluids may be there when there is peripheral PS. And then pleural efficiency, and then hospital signs will include loud P2. How do you say it's loud P2? You compare it to K2. But if it is single, how do you say that? If your K2 is heard at TFX, then it has to be loud. And if it is palpable, it has to be loud, definitely. These are definite situations where you can say K2 is loud in the absence of K2. Then you have RGS3 and S4. You have a constant ejection clip, the murmur of PR, and the ejection systolic murmur, and the murmur of PR. These are the various hospital-related signs of PAs that you can find. So then this PR and PR gives you a very good clue about whether they are high pressure or low pressure. So how to differentiate between high pressure and low pressure PR? It's a pansystolic murmur. This is an early systolic murmur with a variable duration. The pitch is high versus low. The shape is pansystolic murmur versus deep central murmur, and the B2 is loud and other signs of PH will be dominant. Same thing here. High pressure is a Gramsci murmur, which is high pitch, longer duration, with a loud P2 and a narrow split, and a background P2 may be there. The opposite is in low pressure PR. And prominent PR is found in PDA with PH. So this is like another important thing that you may have been knowing is how to differentiate between hyperkinetic pH and isometric syndrome. So hyperkinetic pH still, despite the presence of pH, there will be chances for cardiomegaly and the signs of increased pH. Whereas in isometric syndrome there is no cardiomegaly, there is no flow. And coming to the most important when it comes to isometric syndrome is how do you differentiate between all the three of isometric syndrome. So what are the underlying basic lesions? These are the ones that are there, and these are our own series there. Mostly it's all PhDs predominant in most of the series, and ASDs and PhDs predominant in our series there. So what are the clinical signs unlike in PhD isometric syndrome? Cardiomegaly. Right. So this is a very important table. It's very simple, very easy to understand. The usual age of isometric syndrome is 2 years, mind you. The usual age of symptomatology, symptomatic presentation is 20 years. But the onset of isomerization starts to around 2 years of age. Same thing, it may happen early in a PDA. And differential diagnosis is found only in 50% of patients with PDA. Rest of them have either mild cyanosis or they may have cyanosis in the upper limb also. The cardiomegaly is a feature of ASD, and parasternal leak is a feature of ASD. PR is more commonly found in ASD, whereas PR is more commonly found in PD. The P2 is a very important characteristic distinguishing feature. ASD, it remains wide and fixed, but it may be less wider than before. It never doesn't become narrow. It still remains wide and fixed. Okay? Whereas PDA will be variable. So some of the other ones that I don't want to complete it because I cannot complete everything. These are the other class of cyanosis, mostly found in infants and early infancy. So these are obstructive lesions, and then you have without anything that will include the common atriums and Epstein anomaly. So these are the other ones that are there. So Epstein anomaly is, I think, is a separate topic by itself. I can't cover in 30 minutes, so I am not going to cover because it comes in various sizes and various shapes, various ECGs. So you go and read about that. So I think some of the things that you should know. This is some simple ready-made cakes I am giving you. So what are the pregnancy outcomes is commonly asked in the natural history. So you should know this. So generally look at it, when it comes to the pregnancy outcomes, the worst outcomes are Fontan and the cyanotic allergies. EIVS and cyanotics are the ones that really have the worst fetal outcomes. So other one is the recurrence risk is, whereas isometric syndrome is generally, and ventricular systolic dysfunction are the ones that have worst fetal maternal outcomes. So what is the recurrent risk? This is something that you should remember. So what is the recurrent risk? The previous sibling is affected, the father is affected, the mother is affected. So very simple table that all of you should remember. So it's actually very simple program you have an approach. It's quite simple, and these are some other things that I would suggest that you should go through. I think this cardiology methods you are aware of. Then essential of CG cardiology, which was given in some time back in CSI, that has almost all the chapters that are covered. So I've handpicked the great authors from the country up to the chapters. And then obviously all know that Rajan Chandan's textbook also, Rajan Chandan's approach to clinical cardiology also is really important for all of you. You can treat it in one way. Thank you.
So thank you so much for taking all the trouble bending backwards for us. As usual, it was a real masterful lecture. Since we have got a request from students who are leaving after lunch, ma'am, can I just ask you to continue your talk today now, and then we'll actually break for lunch because some students are leaving after lunch. Ma'am has discussed one part of the hemodynamic part yesterday. She continued today. Thank you.